Good evening, everyone. I'm Wendy Mitchell. I'm a paramedic at Bracken County EMS in northeastern Kentucky. I've been in EMS for 31 years. I started in 1992 as an EMT, and in 1996 I received my paramedic, and I've been working on the truck or in the emergency room since that. No closer to retirement today than I was the day I started. Little side note. Tonight, we're going to do a brief introduction to adult oral tracheal intubation. Um, the objective for tonight, the student will identify the need for oral intubation, know the contraindications, the equipment needed, and successfully intubate. The affective goal tonight, recognizing the need for intubation. The cognitive, knowing the steps and needed equipment for intubation. And then psychomotor is intubation skill with 90% accuracy. I know that's demanding a lot, 90% accuracy. This is a skill that you've just got to get. With the introduction of video laryngoscopy and eye gels on the trucks, this is kind of getting to be a dying art. There's no better protected airway than an orally intubated airway. And direct visualization has kind of gone by the wayside with these new things that are being put on the trucks. But this is a skill that you do need to know and to get as good as you can at, because there's always a chance that video laryngoscope is not going to work for some reason. So you need to practice this. We get our dummies out and practice 2 or 3 times a year, as well as what we do on the trucks, just to make sure we stay up on this skill. Here's a picture of a diagram of the airway, the nasopharyngeal and the oropharyngeal airway. As you can see, the trachea is anterior to the esophagus. Now, when you put your blade in there and look, your vocal cords are going to look a lot smaller than your esophageal opening. That's why it's easy to intubate the esophagus, thinking you're in the vocal cords. It looks like you're going through the vocal cords, but it slides right under them. Reasons to intubate are going to be unconscious without a gag reflex to protect that airway. If patient is apneic or unable to maintain their own airway, if they have a risk for aspiration, severe facial trauma, or inadequate gas exchange. Some of our COPDers might be satting 97, 98%, but they're not exchanging gas well. Sometimes you have to intubate them or put them on BiPAP. They're not going to like it, but, that's what we got to do. Some contraindications and concerns for oral intubation. Obviously, number 1 is esophageal intubation. If you're not in the trachea, you're just not doing any good. You're just ventilating, putting air in the belly, and that's just not doing any good. Too deep in the right main stem, which is an easily fixed problem, and trauma to the teeth, mouth, and airway. Some basic tools that you can get by with for intubation: your tube, a syringe, and an oral airway to use as a bite block. Things that you're going to need for your oral tracheal intubation. You're going to need a laryngoscope blade and handle. And I have an example here. I have the big handle, which actually takes 2 D-size batteries. This is typically an adult intubation handle. Not to say that you can't use it on peds too. The size of the handle doesn't matter. It's the size of the blade. The pediatric handle is about the same length, but it only takes AA batteries. The Miller blades are the straight blades. This is a Miller 4. The Macintosh blades are the curved blades. This is a Mac 3. Typically, for an adult intubation, Miller 4 or Mac 4 are going to be your preferred blades. I just recently found out that I'm one of the few that prefer the Miller blade. I did not know that Macintosh blade is much preferred over the Miller blade. You're going to need a correctly sized ET tube. Most of them come prepackaged now with a stylet in place. We were always told, don't be a hero, use a stylet. You may be able to get by without it, but it's much easier, much safer to go ahead and use that stylet. One thing I like to do before I introduce the tube, before I even start the procedure, uh, inflate your bulb, check it, look at it, make sure that it doesn't have any visual leaks, make sure that it'll hold air, make sure you don't hear any air escaping from it. I've never had it happen, but I have heard tell that once in a while you'll get a compromised bulb that doesn't stay inflated. Your stylet, which is already in this tube. You're going to need a stethoscope for sure to assess for those breath sounds. You're going to need a bag valve mask. One thing I like to do with my bag, uh, once I've taken the mask off after I've ventilated, I take it and just unplug it from the oxygen real quick. Put your tube through there and let it ride on your tube. And that way, if for some reason that airway comes out, you've got your mask. It's not in the floor of the truck or under the cot or something where you don't know where it's at. You're going to need a 10 cc syringe to blow up the bulb on your ET tube. You're going to need suction for sure. That's going to be on probably 99% of your intubations. In Kentucky, we're required to have fixed suction on the wall and a battery operated portable suction and a hand operated pump suction. So we make sure that we have plenty of suction available. You're going to need oxygen and you're going to need a securing device. Whether it be a securing device that you've bought, one of the fancy ones, it's got the screw thing and the bite block built in, or whether it's a shoestring. You're going to need a securing device, and if you're using something like tape or a string, you're going to need to put an oral airway in there to serve as a bite block. Some things that are not necessary, but they're helpful. At Bracken County, we utilize the auto vent. Also, we utilize the Lucas device. So the auto vent, they're great. You put them in, screw it on to the port of your fixed oxygen system. You set your tidal volume and your breaths per minute. Put it on your tube where your bag valve mask goes, and it takes off. So with the use of the auto vent and the Lucas device, basically all we have left to do is push drugs. A bougie, if you've never seen a bougie, it's similar to a stylet. They're usually blue. It's a little thicker than this stylet. And basically what you're going to do is you're going to intubate with that. You're going to pass it through the cords. And then once you've got it through the cords, you're just going to slide your tube over the top of it. And it's going to go right in the airway. And CO2 detectors, these are great. They're very inexpensive. They're single-use disposable. What you'll do is you'll put it on the top of your tube. Once your tube is in, this is one way to check placement. As you can see, it's a purple color right now. If you are in the trachea and it is getting gas exchange, it will turn yellow. If you're in the esophagus, it will stay purple. Now, but you cannot depend on just that one tool there to make sure that you're in the airway. Procedure, you're going to hold your laryngoscope in your left hand. Doesn't matter if you're right-handed or left-handed, you're going to hold it in your left hand. Once you engage your blade on your handle, your light's going to come on. You're going to enter in the right side of the mouth, sweeping the tongue to the left. I always like to hold the blade pretty close up. That gives me more torque on it. You can hold it wherever is comfortable for you, but I hold it way up close. You're going to go the tip of the blade back just a little bit, but the whole blade up and away from you until you can visualize those vocal cords. At this point, you're probably going to need suction before you'll get to see the vocal cords. You're going to take your tube in your right hand and pass it through the vocal cords, your bulb, and then you can remove your laryngoscope and blade. Then you're going to listen for your breath sounds. You're going to oscillate all 4 lung fields. If you can only hear them in the right, then you're probably intubated the right main stem bronchus. It's a more direct path from the trachea, so it's a lot easier to get down in that right main stem. You'll deflate your bulb, back out a centimeter, and reinflate it and ventilate again and reassess your breath sounds. Usually it only takes a centimeter or 2 and you've got that problem fixed. You're going to listen over your epigastrium. It should be silent. Attach your CO2 detector and observe your color change. If you use those, monitor your pulse ox and monitor your capnography. So in conclusion, this oral intubation is an advanced skill used to secure and maintain an airway. Although there can be complications, practice and skill will help the provider master this skill, resulting in saving lives.